these sessions, what I will do is there's one taking place on Wednesday, 9th of April from 7 till 9 p.m. Then another one taking place on Thursday for those practices wishing to join between 12 and 2. But I will put all this information in the chat as we go along, and we'll move on to today's session. So, as already mentioned, so we're going to be joined by colleagues from Health Tech, which is hi Olly, hi Roomi, which is a patient registration tool really to try and a bit of innovation towards all our practices across Nottinghamshire. So we thought we would get those colleagues in to explain the process and what it may be able to offer as a benefit to your practices. And then we'll go to part 2, where we're joined by Dr Manik Arora from East Midlands Ambulance Service, who is Deputy Medical Director, who will give us an update on all things EMAS related and how their impact for practices and the challenges they're facing at the moment. So without further ado, the session is being recorded. I will hand over to Olly and Roomi, if I may.
Thank you very much, Stuart. Hello, everyone.
Hi, folks.
How are you? We have a fun activity to start with, and I'm going to grab my slides and kick off. So just to give you a kind of brief introduction, Stuart's mentioned it already, but we're Health Tech One. We automate new patient registrations. And as a company, when we join the company, we have to decide what our emoji is. And mine is a ladybird, partly because lots of the good animals had already gone, but also because I really like when they land on me in summer. I feel like a real nice connection to them, and they're a sign of good luck. Roomi, yours is...
Can you see our screen yet, folks?
So we can see...
it yet.
It's still blank at the moment.
It's loading.
I need to demand a new laptop.
Yeah, you do. You do. We gave him a bad one. We weren't sure if he was going to be sticking around for long. I'm joking. I am joking. No, so we would love for you to pop into the chat your own emojis. Is there an animal that resonates with you most? Amazing. Jenny, I see you on my screen. Hi, hun. Pop into the chat for us. So Olly said his is a ladybird. Yes, some of the good ones were taken, but I think ladybird's pretty good. I'm an octopus. So my very soppy story is octopuses or octopi, I never know the plural. They have 3 hearts. So one for me, one for my niece, and one for my nephew. So that's me. We have someone who's a dinosaur in the team. I'm not sure if that counts as an animal. I guess one day it was. But yeah, pop into the chat if you're feeling brave. Tell us what your emoji is and why. Will, thank you. Yep, you're an elephant. It's I mean, elephants are supposed to remember things, right? I've got to say, I think Will's memory is actually pretty poor.
He's a colleague of ours.
He's a colleague. I'm not just mocking someone from Nottingham. But no, that's sort of us. But yeah, as you wish, just pop in. We like a lot of energy. You've got like an hour call or hour and a half call. Let's make it exciting. So yeah, that's us. And yeah, we automate new patient registrations. We're going to tell you a bit about the impact that we've had across Nottingham. We've done it across the ICB. Stuart, thank you. Not just any monkey, a monkey with shades. Love it. Lorna Jane, giraffe. Great. I can only assume you're very tall, or you like eating plants. Yeah, cool. So yeah, we're going to tell you about the impact we're already having. We'll tell you about what automated registrations is, and you'll hear from some people who already are automating in Nottinghamshire.
Cool. So to introduce us in a bit more detail, it's really important to know that we're based in a practice in East London, in Stratford Village Surgery. So born and bred here. And our origin story, briefly, is the 2 people that started the company are Raj on the left and Pete on the right. And they came in during COVID to help Raj's parents. So this is Raj's dad on the left. And basically to help with what was a very difficult time, they came in and did a variety of different projects, but ended up focusing on automating the new patient registration process. And there's a variety of different people here. So we have GPs, we have software engineers, ex-admin staff. Also, we're very lucky to have Lawrence here. He's one of the co-founders of Acurex. And everyone who joins the company, regardless of their background, spends time in the admin team here so that we can develop an understanding of the challenges that admin teams across the country face. And basically, our automated registrations started here. And as you're going to hear in a second, they're across the country in over 1,200 practices now. the mission that binds us all together is to give NHS staff one less task. And we're now in 1 in 6 practices, or we're both in 1 in 6 practices and also processing 1 in 6 registrations across the country, very nearly doing 1 in 5 registrations across the country. As I mentioned, we're now in 1,224 practices. The massive number on the bottom left is almost meaningless in terms of how many registrations we've done, but we put it there just to explain that we've refined and refined and refined what we do over many, many, many iterations, and now feel really confident in delivering a gold standard registration to practices. But I think I can definitely speak for both of us and for the company as a whole, where for the quick readers amongst you, you'll have already seen it. The number we're most proud of is the one in the bottom right. So with our automation, we've saved 172 years of NHS staff time so far. So cool what we've done so far, but lots more to do. And the first step is working with more practices like yourselves. So we're not just going to talk at you, but I'm just going to very briefly explain to you how it works. I think we have Jenny and a couple of others who use it already on the call, but I'm just going to give a very high level explanation as to how it works, and then might call on a couple of people to share their experience if that's okay. Basically, for a patient, they won't notice the difference in how they're registering at your practice. So they'll use the NHS app, find a GP, your website. The magic happens when their information is sent into your practice. At the moment, it probably takes about 15 minutes for an admin team member to put registration information into their clinical system. So every patient, 15 minutes time spent to get that information and put it into EMAS or System 1. And basically we automate that. So we put the patient's details into your clinical system. We do all the coding, all the clinical coding, and we text the patient when we're finished. We register patients on the same day. So you're rapidly registering patients with all the coding necessary. And there's just a one-stop shop for your team to see what's going on. They can manage everything. It's just a slick, easy to use portal. So they're not diving around in emails looking for PDFs anymore. It's just all simplified. And I'll pass over to colleagues in a second that have used us, but the balance we're striking is, let's make sure that we're taking as much work as possible off your plate while also doing it safely and keeping you in control. So when we look at all the practices that we work with, we fully automate 85% of their registration. So admin teams don't lift a finger for the vast majority of their registrations. Then there's a small chunk, so 14%, where we need a bit of detective work from admin teams. So like where a patient spelt their name wrong, and the admin team will just go in, check the details, correct them, maybe call the patient, look on the spine, and then they can send everything to be automated. And then a very small number where it's just not appropriate for us to attempt the registration, like where a person doesn't have an NHS number and they're not the same sex as at birth, where we'll hand to your team and your team will do it themselves. But the vast majority of work is taken off your plate. And I can kind of talk to the benefits. You'll have already imagined some of them, time saved, never again having a backlog of patient registrations in your practice, and having an incredibly rich set of data about your patients, which will help you hit quaff from the off. And I'll talk about that more in a second, but I just wondered if anyone that uses this already wants to share a little bit of their experience. I might call on Jenny, if that's okay.
Yes, absolutely. I can take you through how we registered before health tech and explain what we were doing beforehand, and then how that's impacted the surgery and our time within the surgery. So I'll take you through that. So all of our registrations were completed online previously. They came into our clinical system and then they were manually input. So we had administrators and receptionists who would manually input all of those registrations as they came in from the online registrations. Now, we're a little bit different to a lot of the other surgeries, as you know, because we're a huge practice and our intake is quite vast. So we register between 8,000 and 10,000 registrations every September to November. So this has had a huge impact on us. But in relation to all other surgeries, the amount of time that this has saved us is significant and would be for your admin staff. I know a lot of the admin staff in surgeries feel overwhelmed. it's important to keep retention. Sometimes with that overwhelm, you just, you've got so many things to do, being pulled from pillar to post. And it's one of those things that obviously with health tech, these registrations being automated, it's one more thing that they don't need to worry about because it's being done. So our registrations were completed manually online, so we'd have somebody sat processing those manually. Very time consuming when you've got referrals, sit at the reception desk taking calls, dealing with patients, sorting prescriptions out. So just to put in some context, we would have during our main registration period, we would have almost 20 people, sometimes more than 20 people, just inputting manually registrations. And this September, we went down to, we were just having 2 people deal with the queries for just a couple of hours a week. So it's significantly impacted our admin time. Now, within the registration process itself, we've been able to contact health tech with any queries in relation to catchment areas, new addresses, commercial properties, all of those issues that you would have within the registration process itself. And they are hugely responsive. They will answer all of our queries normally within less than a day. So yeah, the coding as well is significantly impacted. The amount of processing that we do, we would quite often have to go back and then send batch text messages out in relation to some of the things on the registrations, in relation to ethnicity, smoking status, BMI. That's all done within the automation process. So you've got your, that's towards your QOF figures there already. That's being done within that process.
Can I ask, Jenny, there was a change, right? Last year, the registration process changed, nationally. So the NHS form got mandated.
Yes.
So one of the things we offer is a configurable local form. So if you imagine in the past, you'd hand this paper form to your new patients and you'd staple a bunch of extra questions, right, folks? And it's very difficult to staple extra sheets of paper to a digital form. So our equivalent of that is the configurable local form. Can you tell us a little bit about that data capture and the impact maybe of national form and having the local form questions, and is it worth it?
Yeah, so we weren't over the moon when the NHS digital form was introduced, but you quickly got on board and configured that for the local form, which meant some of that information can actually be automated from the NHS digital form, which means a lot of those that are done on the NHS digital form through the app can be automated for us as well. And we realised that, from our point of view, because we'd been using health tech, it seemed like a step back, but you quickly put those measures in place for those forms, some of those forms to be automated for us. It's helped a huge amount.
I'm so glad to hear that. Thanks, Jenny. I think we'll call back on you, just conscious of time. Thank you so much. I hope folks have found that interesting. I'd love to see if people don't mind using the raise hand tool. Who else uses Health Tech One already? Just to give us an idea of how much we're preaching to the converted.
Patricia.
So we've got Patricia at Tudor House. Who else have we got? Paula. Carol, St George's. Carol being the crazy emoji, great. Paula, amazing. So I can see 5, 6 hands up so far, 7, and counting. That's really promising. That's really good to know. 8 so far, amazing. So we have 22 practices across Nottinghamshire, at least the ICB, who work with us already. And we can jump in. I'll let Olly just finish up a couple of more slides on the what the actual product entails, and then we can jump into stats.
I don't need to do much because Jenny's done my job. I know most people use System 1, but just one thing to add to Jenny is that we also process GP to GP transfer for the few of you who are using EMAS. And just to reiterate, it's super important that we keep your admin team in control. And we basically, when we register patients, we tell your admin team who we've registered, if there's any important information like them having long-term health conditions, that sort of thing. You can manage, the team manage everything in the hub. It's super easy for them to see the registrations happening. Also, for those of you who are kind of interested in high-level data, there's loads of interesting stuff we can show you, from what's the ethnicity of your patients to why are patients leaving your practice? Because if they leave and then go to another practice using us, we can show you that information. It's kind of been said, but you can customize this in the way that works best for your practice. So do you have branch sites? Do you want to treat people from care homes in a particular way? Do you process out of area registrations? How do you want to assign registrations to different GPs? Do you have a list of patients who you wouldn't want to automatically re-register because they've been deducted through things like aggressive behaviour? You can tell us that list. We've spoken about how you can create additional questions at the end of the NHS form. You can make patients answer more questions. A PM described it to us the other day as doing a health questionnaire at the point of registration. So you can do that exclusively with our form that you can add to the end of the NHS form. And yeah, we will train you and give you all the website links and that sort of thing that you need. We're going to talk briefly about, not specifically.
Yeah. So just impact so far, right? These are interesting numbers to see. So we work with 22 practices, like we said. We've already automated close to 20,000 registrations. Now, this I would say is actually the most interesting number. This is the proportion of work that we're able to remove, right? Imagine if you're spending a couple of hours each day doing registrations, you're removing that, you're able to reallocate that staff time. And yeah, I won't jump into these, but it's a cost saving. We help practices make money, and patients really love this process. More often than not, they're registered on exactly the same day. The average wait time for registration is now 10 hours. I don't know about yourselves, but usually there's a backlog of about 3+ days, sometimes more than a week at some practices. But yeah, all of the feedback that we get, surprisingly efficient enrollment. You've got to love it. Really easy to registered really quickly. Like these are important things. How do we sign up for this, Elizabeth? Great question. I'm actually, if we jump into the next slide. So thank you, Jenny's already spoken to us. If anyone else wants to tell us about their experience as well, we'll have a moment to be able to share that. But if we go into this, so we've got an offer at the moment. We'd like to start a pilot across Nottinghamshire to get practices using us. We're offering 6 weeks free. I'm just about to post into, there we go. If you want to actually click the link, there we go. It's typically £2 per automated registration. We don't lock people into year contracts or anything like that. You leave if you wish to leave. I often describe it like Pringles. Once you pop, you can't stop. Sorry, I know that's cheesy. I know that's cheesy. I'll work on a different line.
I like it.
But yeah, so we're offering 6 weeks free because we'd really like to get as many of your practices on board to really see the impact. If within a few weeks or whatever you're seeing actually we can do this the same in our practice, by all means please carry on. But like I said, £2 per automated registration. We only charge you for what you use. If we if you have to manually process a registration and we're not able to, we're not going to charge you for it. And yeah, you can leave whenever you want. Essentially, we don't need a notice period. You don't need to pay exit fees, nothing like that. Every text message that we send is included in that price. If a whole PCN signs up, you get a 10% discount, so it's £1.80 instead. And we work really closely with a lot of federations and a lot of ICBs actually now in actually getting bigger discounts. So that's kind of our end goal. We'd love to work with the whole patch, but the more of you folks who are interested in using us, the more likely we're able to get to a discounted rate. But yeah, join the list, and then Ollie can tell you a little bit more about what's coming up in the next couple of weeks.
Yeah, thank you, Roomi. We're really conscious this kind of forum is like helpful because we can download a lot of information, but there's not a huge amount of opportunity for us to answer questions and have a conversation. So obviously we'll be sharing the slides. In the slides there are contact details. Stuart will share our contact details, so you can ask us about any individual questions. That's absolutely fine. You can also, we'll make sure you have links where you can book in individual calls with us if you want to learn more. And finally, again, it's in the slides, we have lunch and learns coming up. So there's one on Thursday at 1, and then one the following Thursday at 1, just if you want to come and ask any questions. But I guess just before we sign off, the final thing to reiterate here is you sign the expression of interest. You're not signing up to anything. There's no contract. You're not getting things started. It's just to show us that you're interested, and then we can talk to you in further detail about, more information for your practice, how you would get started. So it's just to let us know that you are interested.
Shall we jump into any questions, Stuart? I know we've maybe gone over time. Do we have 2 minutes? We could take a quick question.
You've got 2 minutes.
Amazing. Yeah, nice one. Any questions, folks? Feel free to just unmute and shout. I know there's 72 people in the call, or raise your hand. We can raise do your hand. No, sorry.
I've got a couple of questions.
Yeah, please go ahead, Stuart.
So one of my questions is about confidentiality and DPIAs and things like that. Obviously, people do sign up. Obviously, no doubt you've gone through the processes of making sure that everything is, checked and balances are in place, etc. in terms of medical information, patient identifiable information. So would you be able to share some of those DPIAs in advance, and we can share those in our newsletter? Absolutely. Just for practices to maybe review and make sure they get all the assurances in place. Another thing is about duplicate patients and merging. So
great question. So with merging, if there's a patient that's been deregistered or they're inactive, we'll just reactivate them in the same way as if you did it manually and you found a patient was registered with you previously. If they've given their information and it's different to what we've got on the clinical system, we'll update that. So usually if a patient's already registered with a practice and they use the registration form, often we find it's just because they're trying to tell the practice their new info. So we'll update that. Yeah, so you won't have duplicates. I'm just going to share the compliance items that we have already in the chat. We'll share it in the comms with you afterwards to share with practices as well. But if anyone's really eager and wanting to look at our DPIA as soon as possible, it's right there. Any other questions, folks? So the kind of quick summary would be, sign up for the expression of interest. Like I said, 6 weeks free, and then you'd roll on to paid, which would be £2 per automated registration. But if your whole PCN signs up, that'll be £1.80. Like I said, we help practices make money. Just get in touch with us. We'll have a link to be able to book in for a call in the email that Stuart will share with you all afterwards as well. But we're super excited to hopefully work with more of you. I was born in Nottingham myself, so I have a real warmth with this group. So yeah, please work with us, see how we are. We really want to take away some of your work.
One final thing, which I just noted that we didn't cover in these slides, is when you're thinking about, is it worth it if we do 6 weeks and then it's £2? The way we think about this is, at the moment, your staff can probably do about 4 registrations in an hour. And if you look at their staff time, that breaks down, that's probably about £15 an hour for their time. So each registration is about £3.75 at the moment in your current world. And obviously we want to roughly half that with £2 per automated registration. So, but 6 weeks free to give us a really good kicking. We'll also hold your hand along that to make sure that you're getting the most out of it. And then you can decide whether to use it or not. Setup takes 20 to 30 minutes, so it's not a kind of big commitment. But yeah, we'll leave you at that.
I can see 4 of you already signed up. Well done. Keep them coming, folks.
Thank you for having us. Thank you for having us.
How do you guys make money then?
How do you mean? How do we make money? It's not us doing the registrations. We train computers to do it. So they work 24/7, 365, no Christmas off, no Eid off. So yeah, that's how we do it. So we've got many robots doing the work. And what's nice is we're not using AI or fancy new technology. This is old school technology. It's called robotic process automation. So, RPA. And what we do, we train it to do exactly what the person is going to do. Because it's repetitive, they just get trained to do if this, then this, if this, then this. So it's super reliable, and we keep track of those. So we work with over 1,200 practices, nearly 20% of the country already. And like we said, people can leave if they wish and they stay. So it's weird, but it works.
In terms of risk then, for patient registration and information that's going from one practice to another, do you hold that risk
So we're the data processor.
Yeah.
Each practice is still the data controller, and we're in a contract with each, right? So we've got our terms and conditions. All of the data that we present back is anonymized. There's no identifiable information. We all have nhs.net email addresses as well. So if there's ever any data transfer that needs to happen, we'll always stick with nhs.net. So it's multi-factor authentication. We have all of our cyber securities plus, etc. So all of that's like locked down. Without sounding really nerdy, whenever DPOs see our compliance items, we get a lot of praise. So we're doing something right on that compliance front. But like I said, yeah, we're the data processor, so we're not going to go in and be doing anything with your data or passing it across to anyone. Okay. Nothing is identifiable. Yeah, really important for us.
Yeah, totally. Thank you, Ollie. Thank you, Roomi. Thank you, Jenny, as well, for talking about the case study for a local practice.
Appreciate it.
Any final questions for the team at all?
I've had a few in the chat, so if folks want to find that link, we've got it in the chat.
Excellent. Thank you very much for coming along today. Lovely to see you both, and hopefully keep in contact.
Yes, absolute pleasure. Thank you both.
Thank you guys. Take care.
Bye.
Okay, we'll move on to part 2 now. Dr Manik Arora, nice to see you.
Thanks, Stu. Can you hear me okay?
We can, yes, thank you.
So I can see loads of initials, so I'm presuming that people normally like to keep the cameras off in this call, which is a bit unusual for me in that scenario. So I can see Michael as well. Hi, Mike. Been on the patch before. I've done a few presentations in different guises in the past, and at the moment I'm trying to figure out what questions you would like me to answer as such. So I do want to light up the chat if there are any questions that you people would like me to answer before I get into the formal things of the information that I would like to share with everybody as well. Those who I haven't met before, Manik Arora, GP by background, Associate Medical Director at East Midlands Ambulance Service. Thanks, Stu, for changing the title to Deputy Medical Director. I've been called other things as well over the time, but it's a much better title than the other things that have been called over the different periods. Before I start on with anything else, I think the pressures within the health service, whether that's within general practice, whether that's within the ambulance service, and all those recent announcements with regards to NHSE and ICBs, I can just imagine that the temperature is getting hotter and hotter, and it doesn't take much to say that things are calming down. Having said that, one of the things which is starting to improve from the ambulance service perspective is the temperature is warming up, and I'm sure that is having a better impact on the handover delays, and the sunshine is having a better impact on handover delays than just the planning guidance which came earlier on in the year. Now, in terms of the planning guidance, it asks for specific things to be done in that urgent and emergency care side of things. Is majority of the hospitals are now looking at implementing 45-minute as a mandated handover timescale. Why is that important for us? Every time an ambulance is stuck outside a hospital for a couple of hours, it's not responding out there and doing the things that it needs to do. And that translates very closely into our response times as well. And it is anticipated that within the planning guidance in the next 1 year, we'll be aiming to get back into that 30-minute Cat 2 mean. So when you're calling for a Category 2 ambulance, we get there within 30 minutes. So this year's planning guidance focus for an ambulance service remains on handovers, C2 mean of 30, as well as improving our hear and treat rates of the numbers that we address in our hear and treat, and setting up clinical hubs to do that. You ask me, why is that relevant? That is directly relevant to everything that we work with primary care. And having said that, before I get into the questions with regards to the planning, I do have a conflict of interest. I still maintain my interest in general practice, and I chair Nottingham City GP Alliance, but I'm here with my background of an ambulance, and I think it's just around there that the ambulance, I keep hoping that it doesn't run me over at times, but not noticed many questions coming through. I do need to take a breath and a pause before I start getting into formal things. Hi, Liz. Because I didn't prepare a slide deck. I can use a slide deck to talk through various things, because I think to myself, I've done slide decks here before. Does the audience really want me to talk about an ambulance service, or are there specific things that you want me to cover? Khalid.
Hi, Manik. You're on the Mid-Knots WhatsApp group, and I think what winds a lot of GPs up is sometimes the perception from the paramedics that a GP will respond quickly within 10 minutes. If in a single-handed practice or smaller practice, it's not always, doable. We will try and ring back as soon as we can, but we hear impatience from paramedics.
I'll come to that bit, Khalid. It's a point that I'll note, and I'll try and cover as many points, and I'll come to that definitely, because I think it's a really important point for us to cover. Are there any other things that people still? Would you like me to cover anything else as well?
It's just in relation to the WhatsApp group for Nottingham and Nottinghamshire, where we've seen, colleagues from general practice putting comments within the chat for their experiences. And I think one of those is about onward referrals. And recently there was one to AMRA, and I know you're going to be involved in that as well, Manik. So it'd be really good to maybe just talk about escalation and, on certain maybe engagements with frontline crews that practices may be experiencing. But I know obviously you're fully aware of some of the things that we discuss.
Okay, so I'll cover that one as well. And Jeremy, you put the thing with regards to the changes which are going to be having an impact. Well, some of us GPs, me and Nicole, have been around in EMAS as well. Now, in one sense, I've got a deadline of making sure that I get maximum out of Nicole in next 6 weeks while she's at EMAS, because some of you would have heard the news that she's moving to City Care as the new chief executive of City Care. So interesting times ahead for all of us, and particularly those more closely impacted by changes in City, because that will be a one to watch with regards to how the neighborhood teams and that scene evolves as well. Jeremy, in terms of your question, before I come to the scenario of the interactions within the workforce at the front line, what I have to acknowledge is the national policy drive when we're talking about moving care from hospitals to community. And what does that mean for us? When it comes to the frail population, when it comes to elderly population or end-of-life population, where are we heading with that scenario? And we are already starting to see some of those challenges being and manifesting into those issues. 2035 is the projected time when we're going to be having about 30% of Nottingham and Nottinghamshire population hitting that 30% mark of frail older people. But in Lincoln, it's 5 years early for us. And the questions which are coming about is, how do we support the people, those complex scenarios as MDTs in community without necessarily always conveying them to the hospital? Is hospital always the right place for them? And it's an important question for us as much as an ambulance service, because looking at some of those videos in terms of the policies to what an ambulance service does, and I can share that in a later point. One of them was done in 2016, which starts talking about an ambulance service, not which is always conveying to the hospital, but what can be done to support them in the community. And to me, that is the key aspect. There is, I would say, a grit and a friction between the way different sectors work, the urgency which is felt, exactly what you said there, Khalid, with regards to how general practice operates and the timescales within an emergency and ambulance service. Now, while as an organization, there is always the question of values with regards to civility and kindness of the workforce as well, and looking after them. And we will advise our crews to be saying, if you need to get in touch with the GP, You can try for up to 30 minutes, but if it's not working, then move on, move to the next option. It's not necessarily the only thing that they're going to be doing. At the same time, the frontline crews will have other divisional support. They'll have support from the divisional senior clinical leaders. They'll have the support from the specialist practitioners and within the CAD team or the pathway providers as well. But at the same time, we do need a discussion on how do we have a good case discussion with regards to a complex, frail individual. Now, some of those WhatsApp chats have gone into, I would say, a space where those discussions have moved more in the space of purely the contract, but also with the question of the patient side of things and the complexity. And I don't think they can always be answered in the 10 minutes that we have in front of an emergency scenario, but we probably need to learn from them. And that is where the message which I would like to share. In EMAS, we have well in excess of 4,500 staff. We are divided between 5 different A&E divisions, which are responding in the field, plus an EOC division and the non-emergency patient transport. Plus, like general practice, we have locums. But in the case of an ambulance service, those locums come with their own vans or trucks, as we would call them in an ambulance service. So you can have a crew with their own private ambulance service. And it is important for us to be able to understand where the scenario is coming from. Now, when I used to be in the ICB side and those who have sent a newsletter, and similarly from the LMC side of things as well, when you send out a newsletter, you know that 100% of the people are not going to read it. Comms people will tell me that 25 to 30% will read it at most, and that's a pretty good number if 30% read it. So the challenge always remains that how do we ensure that the message reaches to everybody? And we need to be able to be in a place to learn and support those individuals who haven't always had the message come through. How do we create that environment of learning? And if people are feeling under pressure, and this is where I find myself quite often, that people are feeling that much under pressure, both in primary care and in the urgent emergency sections, that those tempers are starting to fray. How do we calm things down? And the last thing we can do is to add more temper into it, and that doesn't calm anything down. So that would be my plea. How do we maintain kindness to each other? And that's the same message we are sending down to the staff as well. The divisional senior clinical leaders will be speaking to the paramedics. How do we keep the focus on the patient as well as maintaining civility and kindness? And that's the same thing we would be trying to work towards. Now, every now and then, somebody does go out of line. And when those messages are flagged, and I know some people have got in touch with me directly, some people would put that in a WhatsApp note, and again, through the LMC as well. Those calls would normally be escalated onto what is called a service-to-service referral form. EMAS's PAL's website email address is available on the website. I can more than happily share that afterwards as well. Or I'll try and see if I can put that in the chat while I'm talking to you. And we'll look into each one of them. Each one of those scenarios is looked into. And the commonest theme which is coming around from the clinical workforce is how do we manage that complexity and how do we support that complexity? And I'll come to the summary care records. That's a good prompt, and I'll come to that. Now, for the complex and frail individuals, this is where, while we would think of district nurses as our community team, our community matron as a community team, the question which is also there is how do we work with paramedics as a part of that MDT in that neighborhood environment? And at the moment, I don't think we have always got the answer because of the different working models. I've spoken with Michael in the past as well, and very recently, and the question is, what are the working arrangements we can come to? Khalid absolutely accept the point of 10 minutes is not going to be possible. If I'm having a bereavement consultation or a mental health consultation, 10 minutes is not always possible to come out of it. But then 30 minutes, how do we get there? What happens to the crew when they're waiting there? And we would suggest that they move on, to get to the next point of decision making. Now, at the same point, how do we support them with the seniors and the complex decision making? So there are two aspects which I see coming around in the chat quite often. One is the supervision, and second is the complex decision making. As in each individual separate organization, the responsibility for training those individuals and ability to make their own decisions as you would clinical supervise any of your trainees, that responsibility for EMAS sits with EMAS. We will take responsibility for learning and development and those supervision side of things. But when it comes to cross-functional, cross-boundary MDT discussions and making shared decisions, there is a question on how do we address that as a part of our NHS care. And that MDT working is essential, but we probably need to develop it a little bit more. And I'll want to keep that idea of what is the supervision, but what is the shared decision making across complex frail individuals. Some of the recent reviews which have come about in those service-to-service escalations have been around where a patient has called primary care or a patient has called a specialist team, and the patient or the family member has then been advised to ring 999. The 999 call handler has received the call, taken the call, but then the family member has conveyed one aspect of the history, but they've not been able to convey the same kind of background and the urgency which those clinicians had access to. And that information was missing. So the EMA, the call handler, will only be able, following the pathways guidance, is only able to make decisions or recommend follow the pathways triage protocols based on the information which is in front of them. And one of the key learnings for in those scenarios has been the utilization of healthcare professional line. Now, if you want to use a healthcare professional line, you do not have to have the patient in front of you, even if the patient has arrested. The first two questions will always be, is the patient alert? Is the patient breathing? And you can say, no, the patient is not alert, patient is not breathing, but I'm a healthcare professional, and you can provide. And that gets a very different clinical outcome in scenarios. Now, I'll give you this scenario which we reviewed recently. A patient was short of breath, was more drowsy, slightly more drowsy than usual, leg swellings, background of heart failure, known to have pancreatic cancer, and was really wife was really worried, and wife's sister rang the GP surgery. GP knew that the patient also had a pancreatic cancer, and advised them to ring 999. When the wife called ambulance service, she said, yeah, he's a bit more sleepy, his legs are swollen, and he's struggling to get to the toilet. That meant a Cat 3 response, or asking back to the GP for an appointment for shortness of breath. The GP visited, actually rang the healthcare professional line and said, this patient has a pancreatic, these are the things I'm worried about. There's a sepsis is concerned here, and that background history of pancreatic, they got a Cat 2 response. And to me, there's the case of how do we do a handover, not just from primary care to EMAS to primary care, but also from primary care into an ambulance service. How do we get that information coming across? And we can probably be finding much more better ways of working. So healthcare professional line, again, I'll put that in the chat as well, but that number is 0115 967 5099. Healthcare professional line. So you can tell I don't have anybody else along with me, so I'm typing it as I go along, and I'm putting that in the chat. I hope I've got it right. And the other question which I've often had is, if a patient is being rang, so when I've said about the healthcare professional line, are the calls from a GP surgery treated differently in terms of a response if they're coming from a GP surgery? Now, I previously said, in terms of a response, no, they're not treated any differently. But I'm going to change my line slightly, and it has to be said with nuance. When it comes to the triage, a call coming in, they join slightly different. So we have a category 1 response, we have a category 2, category 3, and category 4. A call coming from a GP surgery or a healthcare professional, whether that's from a hospital side, say a Links Bar or City Hospital, or a GP surgery, will be going into HCP categorization 1, HCP categorization 2, category 3. But that is on par with Cat 1, Cat 2, Cat 3. It's with the additional information. There is an equity of response, but there's additional information in the triage. So I would like to assure colleagues that when it comes to the response, everybody gets a similar response timescales. So if it's a Cat 2, if somebody is having a heart attack and a chest pains, which are consistent with a STEMI, they will get the same response whether they are on a hospital premises, in a GP surgery, or in their own home. Now, it's a sad state of affairs when it comes to Cat 3 response timescales. They are not where anybody would be happy with. So I wanted to cover that point with regards to the healthcare professional response side of things as well. So, James, with regards to your question, if a patient is safe to leave at home and the paramedics, so the messages that we are pushing to the paramedics, and I would probably be getting, and I've shared a poster in the past with why am I contacting a GP. Now, if speaking to a clinician can change the outcome of what is happening with the response, they will try and get in touch with the clinician to change the outcome. Out of hours, that can be NEMS across Nottinghamshire. In hours, that can be a general practice. Now, if we're not able to get in touch with general practice, they will end up resorting to the next thing, which sometimes can be conveyance, but conveyance may not be the right thing. On the other hand, if contacting a healthcare professional does not change the outcome, exactly as you said, then the advice to the paramedics or the crews or the paramedic technicians is don't ring the GP. Use the electronic patient record. We've got the GP. It used to be called the GP action box. We took that feedback that people were saying, why are we being instructed? It's a handover box where information is being handed, is being written in the scope of, this is what we have done, we have attended, please look into the follow-up. And some of the scenarios, for example, were we have responded to this individual with diabetes. They have had a major hypo. We have treated their hypo, but you may want to follow them up, especially with regards to the follow-up guidance on major hypoglycemia episodes. So that's where now my question, and sometimes I get a concern from the paramedics, is, are we sure that the primary care is looking at those boxes of GP handovers? What is the kind of time scale? What do we put in there? What if they need a follow-up within 2 days? What is if they need a follow-up within a week? What about if they need a follow-up within 2? What is reasonable? And that reasonable is a tricky one when it comes to an ambulance service compared to a hospital admission side of things. So it's an ongoing question, and probably I'm looking at chats and for any comments and thoughts as well, but one that we'll end up debating and needing to come some kind of a solution, because that's where Jeremy, your original question of what is me and Nicole being in the trust mean, but I asked the question of the national UVC leads as well, that when they talk about a policy change of moving from hospitals to community, this is what it means for moving from hospital to community. What are the new standards? How do we support our primary care colleagues and our community colleagues to be able to respond? We have attended, we've done something, now what? Where do we go from there? Now, the suggestion. So I've covered in my chat so far the supervision of the colleagues with regards to the complex and frail cases, the healthcare professional lines, as well as some things which have come before in the HCP calls, plus the learning from some of those service-to-service reviews. My only things with the feedback on service-to-service review escalations is, I take a point that taking calls from healthcare professionals and EMAS or an ambulance service is not within the contract. I accept that bit, but then I do ask myself, how do we create an appropriate handover in a timely manner? And leaving that completely in, at the moment, how can an ambulance service get a confidence? How can we support them with improving that confidence that if they are putting that in the EPRF, that will be picked up in a timely manner? And what is that timely manner? That is an open question. I don't think I can answer that within the trust, because it's a question of an interface between an ambulance service and primary care. And working across 6 ICBs, I've not actually seen a single standard being agreed or anybody coming to. I've seen answers from some primary care colleagues saying 2 days, and I'm saying, really? Some saying 7 days, and then saying that's not going to be possible in an emergency setting. So what is realistic? So those were the points that I had noted. Khalid, does that answer your question as well? Give me a thumbs up, because I think I can still see you on the cameras up. If not, I'll try and delve more into it.
I think it does answer my question. The problem is clinicians on both sides. I think sometimes we hear that EMAS staff think this is a mandatory thing, 10 minutes, and if GP is not responding, we're going to report you, and that sort of, and that just takes the conversation, escalates it unnecessarily.
So I think there are two different things here. And the work that is being done to ensure, so this case of why am I contacting a GP, the poster which was done and has been shared with all colleagues, and we're working, that work is focusing on reducing the level of contact that clinicians need to make in the first place. Where they're contacting within the right time frame. And there is support from the clinical leads, the divisional senior clinical leaders or the SPs, and to say, if the GP has not been able to get back to you within 30 minutes, move to the next option, treat it in the best opportunity that you have. At the same time, there is a concern that clinicians are also finding that they are having to convey individuals to hospital when they don't feel that that is the right place for the person. And the frustration, and I'm not going to excuse the frustration in any manner, is being vented. And finding those individual options or moments when they're happening and calming things down is what I'm finding that is most often required. One of the scenarios which got publicity from one of the other ICBs was where a crew got frustrated and there was a theme around, oh yeah, you don't ring that sign because what you always get is a delay. And somebody ended up saying, we'll refer you to the CQC. What happens from the crew's point of view? So now crews can do two things in that scenario. If they want an organizational response, and if they're wanting the things to be done on behalf of the organization, they will escalate it internally. NUH have the DATIC systems, we have the Ulysses or the IR1s, they'll raise an internal IR1. And that will be a safeguarding or a concern for they're worried that a care may not have been optimum. And we will review it. And sometimes, like I get the primary care IR1s coming, or the service to service coming through, we will also ask of primary care of what happened in that scenario, and we'll keep a balanced view of what was the best optimum thing to be done. Has there been a single CQC referral or the GMC referral that I'm aware of in the last couple of years? The answer is no. Now, that's the first scenario. The second scenario is where an individual clinician decides to do something themselves as a member of public and approaches the organization, the regulatory body directly. Again, I've heard of the tempers being frayed to that level, but again, message across to the organization is we need to collaborate, we need to work with the partners, the values of civility and kindness are there. but every now and then you have to go to the person and say, are these the standards that we want to work with? So, Khaled, all I can say is that where those calls have been identified, and if they get escalated, they do get looked into, and the feedback is there for the clinicians, because that is not the norm. If as an organization we're taking 3,500 calls on a daily basis, we're responding to 1,700 or more incidents, I do hear of a scenario across the 5 counties, maybe once every couple of weeks, and that has to be looked into with that proportionality. But those individual clinicians do get the feedback of what are the organizational values and what should be the norms in that scenario. But at the same time, I think sometimes, and I'm saying this with pain, but sometimes we also get an aggression on the telephone lines to say, you're not meant to do this, you're not doing that, I'm going to be reporting you. And all you get is an escalation with an escalation, and that just keeps going up and up. And I've listened to those recordings as well, and I think to myself, how do I calm this one down? Who's wrong in this one? And that's being absolutely honest and open when I've listened to those recordings. Is that fair before I move to Jeremy's point? Yep, thank you. So, Jeremy, your point with regards to the practice liaison officers from EMAS paramedics to be having a two-way liaison as well. I think that's the space we need to get into. We need to get into that, the space of collaboration to what does that mean? And when I speak to Greg Cox, our divisional director, when I speak to our divisional senior management teams for quality and the clinical leads, they're all up for what would that relationship be and how can it be different. Now, that discussion in space, we really need to explore more of, and at the same time, what would be the geography to be able to do that in a meaningful manner. One of the case incidents which came a couple of months ago was a 50-year-old individual, so with a lung cancer. The daughter had rang the GP surgery. They had no appointments. Then the daughter rang the district nurse, who said dial 999. The crew got there and felt that the patient could have done with anticipatory medicine, a bit of Oromorph as well. But then they got into, do we take calls or don't we take calls? And this scenario became difficult. In the end, the divisional senior clinical lead went along to the practice. We sat down between a few of us as GPs, few nurses, and we just had a learning discussion on significant event together. What do we do as a learning point? We pushed that across to the clinicians. And the main learning which came within EMAS is that respect forms, they will have a fair bit of information. Sometimes paramedics ask for too concise, too detailed. That's not always going to be possible, but equally it went the other way around for the practice as well, that we need a bit more contextual information and what can be done in the medication side of things. And I would say there was learning for both sides in the clinical teams. I would even go beyond what you're suggesting, Jeremy. It's not just the liaison officer. We need shared learning opportunities together as well. Because again, if I keep coming back to the biggest cohorts that are increasing in number are the frail older people and the end of life scenarios as well. And if we're going to be able to deal with them in a meaningful manner, unless we understand each other and unless we're working across boundaries, we will have that friction. And the only people who suffer, apart from the clinicians having the moral injury, are the patients as well. So again, absolutely up for that. How do we build that? How do we the annual meeting? And if there are any suggestions, again, I'm surprisingly, Michael, you have come on my screen at the same time, and it feeds into our discussions on what those principles can be, on how do we get this going further in terms of how do we get this going.
Yeah, should I just say that Manik? Yeah, I mean, I think that's a commitment. I think Jeremy's got some really interesting ideas, and also, I think beyond, as you say, beyond an annual thing, we can make this much more kind of business as usual, the way we relate to each other. But yeah, I think we'd like to work with EMAS on shared principles, on looking at some case studies and how we can improve the interface. we know that there's some red lines and things around indemnity and contracts, but actually just having a way of working that really makes sense. It has input from GPs and colleagues, practice managers and others, and EMAS colleagues. And if we can make it much easier for us to work together operationally across the boundaries more regularly, then we've got to think about how we can do it. So that's the work that we definitely want to work with you on.
Yep. Thanks, Michael. And I'll finish in the next 5 minutes, or rather 2 minutes, because people will have to drop off. I'd probably gone over the time limit. In the last year or so of moving across to EMAS from the ICB side and the CCG before, some of the things that we ended up learning around being the responsible officer here don't have that many connections, but still with the GMC side, as well as working with NHS resolutions. The whole question of what we can get into the contractual scenarios of what is within the limits or not. But actually, all these things also allow us to work across our teams in a collaborative manner and do expect that MDT team working. So there are solutions which are there in possibly within our grasp as well if you want to explore it. Nobody's going to go and tell us off completely by saying, why did you have a mutual discussion and come to a shared decision here? Probably. Or when I start looking at some of the indemnity questions, they come more in the space of breakdown of communication of why didn't you actually share that bit of knowledge with each other? So let's explore this further. How can we work together? What can be done in that space with regards to improving that working arrangement? But at the same time, there is a lot which can be done, lots of learning. I haven't gone into the unified care records with the work that is being done. That's probably for another day. And if we do end up getting these 6 monthly or a yearly learning scenarios or joint learning, we'll probably start sharing more and more. I am excited about the clinical hub work which is being done in EOC here. That does mean that there will be more here in treat, but it does actually mean that if we don't have primary care which is supported in a consistent manner, there will be more challenges ahead. So do want to build the solutions together. And this is where I do want to work with, and I'm much more closely working in that NCGPA with city primary care side of things, to what can that mean? But again, open for discussion. I'm struggling with my answers because that's the nebulous cloud bit that we have to actually give a shape to, rather than coming along with an answer here and now. So I think so. James, just in the mindful of the time scenario of there are questions with regards to that responsibility and what does that word mean, and we can have the responsibility in terms of a handover to what does that mean as well, and we can end up exploring it, and I'm probably not going to be able to come to a conclusive answer in the next 2 or 3 minutes that we have left. But at the same time, what does that, if we contribute to a decision in an MDT, we're not the only person making a decision, but we are a party to that decision collectively.
I completely agree. But unfortunately, that's not the experiences. The experience is when I say, yes, that person could be seen next week, and they say, no, it needs to be today.
And I think that's the bit of the message where we're taking it to the front line as well, to what is that assessment. And it has been a scenario of where the demand on services is such that where we are saying clinically it's one thing which is appropriate, but the pressures are also saying another thing. And how do we land to a shared understanding of what the expectation and reality is? Because at the same time, I can see from general practice perspective that same day or next day is not possible. At the same time, like that diabetic in a hypoglycemia scenario, there's a question of should every major hypoglycemia be reviewed within 48 hours of having a major hypo? And that's a very fine balance. On one side, you have expectations from the guidelines, and the other side, you have the expectations from the realistic demands as well. So it's that's where I would say both sides can learn far more from each other, and the more they interact and the more they end up in that shared learning space, the better it will be, because otherwise we're sending a message to individual clinicians, but we're not changing cultures. So that's, I think I've taken more than my half-an-hour slot, Stu, unless I've got it wrong that I didn't have a half-an-hour slot or I had longer.
Hi, Manik. Stu's had to jump off. It's Lucy. Stu's had to jump off because he's got another meeting. Thank you for your time today. I think we'll leave it there for now, but I can clearly see that the door's open in terms of engagement, and you have a commitment from us as an LMC to work collaboratively with you in the best interests of the patients. Obviously, we can always get caught up in the black and white details of the contract, but remembering there is a patient at the bottom of this. So thank you for your engagement today. We look forward to working constructively with you as we go forward, and hopefully get you back in a couple of months to update on the changes that are being made in EMAS and likewise.
No, thanks, Lucy, and we'll have more things, and let's get those discussions going further.
Thanks, Manik.
Take care, everybody.
Bye.